Okay, hello, good night, everybody. Welcome to a new edition of the Americas webinar series. In this special time, we have an amazing guest who is collaborating with us, which is the International Pharmaceutical Students Federation, the Pan America Regional Office. So tonight's webinar will be on comprehensive sexual education and contraceptive methods. It will be facilitated by Fatima Rodriguez, our SCORE RA for Americas, and Ethan Brenneman, the Regional Projects Officer for IPSF FARA. So thank you so much, and I hope you enjoy. Fatih, you have the floor.
Thank you, Maho, and welcome, guys, to this new webinar session. So the topic for today is CSE, Comprehensive Sexuality Education, and Contraceptive Methods. So we have like two sessions in one because the first topic is talk about the CSE in general and share general information. And after that, we are going to talk about the relation to CSE and contraceptive methods. So we need to start with the concept of CSE. So when we talk about CSE, we need to understand, we talk about a curriculum-based process of teaching and learning about sexuality in a comprehensive way. So we teach about sexuality in a cognitive, emotional, and physical and social level. So with this, we try to have we want to share skills and knowledge for the young people, and with this knowledge they can have a responsible sexual development. So when we talk about CSE, we have some components inside to this huge definition. So when we talk about CSE, we talk about human development, anatomy, and reproductive health in general. So we, in this part, talk about the physiological and anatomical changes in the body in general. The second component is contraception methods, childbirth, and STEs, including HIV. So we can make a relation between human development and, for example, family planning. The third component is talk about discrimination and sexual abuse. In this part, we can share some skills and some important knowledge for detect toxic relationships, or for detect, for example, when it's happening sexual abuse or sexual harassment, etc. The next component is talk about human rights, gender and gender equality. So in this point, we can talk, for example, about sexual and reproductive health and rights. What is sexual and reproductive health and rights? We can talk about gender equality, gender roles, etc. And the next component is talk about SOGIES. SOGIES means sexual orientation, gender identity, gender expression, and sexual characteristics. So in this part of CSE, we can include, for example, gender roles, what is sexual identity, what is gender identity, gender orientation, and gender diversity. And the last component of CSE is discussions about family life relationships, healthy relationships, conflict management, and culture in general. So when we talk about sexuality and when we talk about sex, we have some components too. So when we talk about sexuality, we need to include the values of beliefs around sexuality and sex, the positive body appearance, thoughts and feelings about the relationships in general, and talking about sex too. We can talk about gender, again, gender diversity, gender identity, gender expression, and gender roles. And the last component of sexuality is relationships and communication skills. So why is important talk about CSE? Why is important share information about sexuality education? So the first thing, and I think the most important thing, is too many young people receive confusion conflicting information about sexuality and about sex in general. So right now we live in a super hyper sexualized world. We have easy access to sexual information. For us is easy access to, for example, pornography. We can have easy access to sexual content. We hear about sex in music. We watch sex in TV, in series in general. So as you can see, we live in a super sexualized world, but we don't have enough information how we can have a healthy and responsible sexuality. So that's the main thing and the most important thing for talk about CSE in general. The second point is because right now in the Americas region we have a lot of consequences related with the irresponsible sexual behavior. So if we talk about CSE, we can prevent, for example, unwanted pregnancies, we can prevent unhealthy abortions, and we can prevent STIs in general. So we can teach and share necessary skills to have responsible sexual development. The third point is because when we teach about CSE, we can prevent STIs in general. Right now in the region, the 25% of the new HIV infections per year are related with young people. So when we teach about CSE, we can be responsible and we can have a better knowledge about sexuality in general and how we can enjoy the sexual life, but in a responsible manner. And the fourth point is CSE is important because when we talk about CSE, we can understand about what is a healthy and what is an unhealthy relation, and how we can prevent, for example, sexual abuse, how we can prevent living a toxic relation, and how we can use good communication skills, and how we can have a good conflict management inside to a toxic relation. So we can empower the young people with this information, and they can take good decisions around the relationships in general, not just sexual relationships. They can be responsible in the relationships in general inside to the society. And the last point, and one of the most important, is because when we teach about CSE, when we teach about comprehensive sexuality education, we can teach about sexual diversity in general. We can teach about the diversity in the society, and obviously we can share why it's important be respectful with the diversity and how we can be inclusive, and we can create and construct better spaces, more inclusive and safe spaces for the diversity in general. And with this, we can prevent stigma, we can prevent discrimination, and we can create a better world for all the diverse people around the society. So we, with this sharing about diversity inside to the CSE, we can create a more inclusive society for all the people. And we have some evidence about the CSE and the good results in the region and the good results around the world. So when we teach about CSE, we teach about sexuality, and this has positive effects because this CSE in the positive effects include the increasing young people knowledge and improving their attitudes related to sexual and reproductive health and behaviors, so they can be responsible for the sexuality in general, and they can take good decisions around the sexual intercourse. The second point is because the sexuality education can prevent STIs, and obviously the young people can know if they are having a sexual risk, or if they are having a risk behavior around sexuality, and they can use, for example, contraceptive methods, and they can be responsible and prevent new STIs infections. And against to the general feeling about CSE, all the programs that promote abstinence as the only options have been found to be ineffective, because obviously, even if we don't want to talk about sex, even if we don't want to talk about sexuality in general, the young people is having sex in an unhealthy and an irresponsible way. So even if we teach about abstinence, if a young people want to have sex, they are going to have sex. So obviously, if we just talk about abstinence, this can be ineffective because we live in a super hypersexualized world. And we can have a gender focused program inside to the CSE, so we can create a more inclusive environment for all the genders in general, not just the binary system. We can create a more inclusive environment for all the non-binary system of genders, and we can destroy some gender roles, some toxic gender roles. And right now, the link between CSE and contraceptive methods is necessary. When we talk about this link, it's necessary to talk about what is sexual and reproductive health and what is sexual and reproductive rights. So, according to UNFPA, a good sexual and reproductive health is a state of complete physical and mental and social well-being in all matters relating to reproductive system. So when we have a good and healthy sexual and reproductive system, we teach about how the people can enjoy sexuality in a responsible way, and how they can say if they want to reproduce themselves or not. So they can have like they can enjoy sexuality, or they can have a reproductive sexuality too. So, why is necessary CSE, and why is necessary talk about contraceptive methods in the region? Is because the adolescents pregnancies, because we have some statistics here. So in the region, 1 in 5 births are related to adolescent mothers, and the region have the second higher rate of teenage pregnancies and unhealthy abortions. And the 38% of all the pregnancies around the world are related with the teenagers too. So for that is necessary talk about CSE, and for that is necessary talk about contraceptive methods inside to the region. So right now, I open the space for Ethan, and for the second topic, CSE and contraceptive methods. Ethan, the floor is yours.
Awesome. Thank you for that great presentation. So hello, everybody. My name is Ethan Brenneman, and I'm with the International Pharmacy Student Federation. I'm a fourth-year pharmacy student in North Carolina in the United States. In the United States, the pharmacy program is a doctorate of pharmacy, which is a 4-year program that we start after undergraduate. So I did 3 years of undergraduate, and now am in year 7 of studies. And hopefully, I'm in my last year of clinical rotations, and we'll hopefully go to a residency next year. So you can change the slide. So this is just a graphic overview of all the common forms of contraception that are used today, ranked by effectiveness and with a little blurb about each. This is something by the World Health Organization that I find is a really useful graphic for sharing with people to show that there's many options, whether you want reversible or permanent, and whether you want hormonal or drug-free. You can go to the next slide. So the common non-pharmacologic contraceptive methods, one is periodic abstinence. This is just withholding for sex during certain days of the female cycle in order to prevent pregnancy. This is generally days 11 through 18 after the first day of menses or period. And basically you're just trying to time it so that you're only having sex during periods where there's no egg that could be fertilized. This method, of course, isn't the most effective, as there are variations in a woman's cycle from month to month, and sperm can live inside the vagina for multiple days at a time. So this kind of thing requires good scheduling on the woman's cycle and being, abstinent when you're supposed to be. But again, it's not the most effective method, but it is free and anyone can do it. Barrier techniques are the very common method that we all know of, like condoms, both male and female, but there are also different forms such as cervical caps, sponges, and diaphragms. These methods are more effective than abstinence, and condoms have the added benefit of reducing the spread of STDs or STIs. Again, one of the downsides with the barrier techniques is that it requires the people to use them correctly every time they have sexual intercourse in order to have effective protection. So you can have errors or issues, or the barrier can break, or various things which lead to the decreased efficacy versus other methods. And then you have sterilization, which is one of the most effective methods, but it's also a permanent or irreversible method. This would be cutting or tying the vasa differentia in men's, or blocking or cutting the fallopian tubes in women. This basically prevents either sperm from being produced and leaving the eggs, leaving the testes, or from eggs leaving the ovaries. So again, these are something that you probably do later in life after your childbearing years, or when, this is a big decision because those are permanent. Those are the common non-pharmacologic methods. Go to the next slide. So before I go over all the hormonal and pharmacologic methods, I just wanted to go over the female hormone cycle during her period or time. So starting with day one, which is menses, this is your period where the follicle starts growing in the ovaries. And so over a 14-day period, the follicle continues to grow and slowly releases more and more estrogen or estradiol. And this period ends with a surge in estrogen and luteinizing hormone, or LH, and follicular stimulating hormone, or FSH. And this surge causes the release of the egg from the ovaries that travel down the fallopian tube to the uterus, or ovulation. So this is the period after that is when a woman is most fertile. And this is followed by the corpus luteum, or where the egg is degrading over time unless there is impregnation. So this is a typical 28-day cycle. And most hormonal contraceptives work by increasing levels of progesterone and estradiol. And these increased levels prevent the LH and FSH surge. So therefore there's no ovulation, and then there's no egg to be fertilized during sex. You can go to the next slide. So some of the pharmacological contraceptive methods, one is spermicide, or nonoxynol 9. This works to reduce the surface tension of the sperm, which can kill the sperm as well as slow its mobility. These are actually not recommended by the WHO or CDC, the WHO, or the CDC for protection against STIs, because frequent use of spermicides actually increases your risk of spreading HIV. And this is due to damage to the endometrial layer in the female that actually increases absorption of STDs like HIV. So its use really isn't recommended as much. It can become like with condoms sprayed on its own or in a sponge. And this sponge, if used, shouldn't be left in for more than 24 hours due to the risk of toxic shock syndrome, which is a systematic infection just from absorption of bacteria from the sponge into the woman. And then you have the female hormonal contraceptives, which are progestin and estrogen. The progestin and estrogen, as I mentioned earlier, block the LH and FSH surge, which prevent ovulation. The progestin also thickens cervical mucus to prevent sperm penetration, as well as slow tubule motility and delay sperm transport. Estrogens also help regulate the hormonal cycle, which is one of the benefits of hormonal contraceptive, is that women get regular periods. You can go to the next slide. So the pill, this is one of the most common forms. This can be a combined hormonal contraceptive with estrogen and progestin, or it can be progestin only. There's also many different types of estrogens and progestins, both synthetic and hormonal estrogen. So when selecting what kind of pill a patient would start on, there are multiple factors you can consider. For example, in an underweight patient, you may start with a lower dose of estrogen and progestin than you would for an obese patient. And you can also do different types of progestin. So if a patient had a lot of acne and wanted that reduced, you would use low androgenic progestins to help reduce their acne levels. Another common form is subdermal progestin, or the implant. This is a procedure where they inject it in your upper arm. The name brand in the United States is Nexplanon, and this can last for up to 3 years, which is a benefit of its long-term use. So you get it once and not have to worry about it for a long time. The implant has efficacy concerns in obese patients and should be used with caution in obese patients. You have the intramuscular injection, or the Depo-Provera shot, which is a progestin that's intramuscular injection in the upper arm that can last for 3 months. One of the interesting things to note about this injection is that it's actually The drug in it has been shown to reduce sickle cell crises. So this is a good type of contraceptive to use in women with sickle cell anemia. And then we have the patch, which is applied usually every week. Oh, sorry, if you could go back. And that's applied to the butt, abdomen, or upper arm area. This one is pretty easy to use and used typically 3 weeks on with 1 week off where you would have your period. And then you have the vaginal ring, which can be inserted at home. And that one lasts for 3 weeks, again, with 3 weeks on and 1 week off in order to have the period. A lot of the pill, the patch, and the ring allow normal period cycles so that the woman will know when every month she should expect menses. Now you can go to the next one. So another form is IUDs, or intrauterine devices. These are devices that are inserted in a clinic through the cervix into the uterus, and these slowly release progestin over time or are copper, and they can last for an extended period of time. So the progestin only slowly release it over 3 to 6 years. These have an added benefit of lowered systemic hormone levels than oral contraceptives. And these can also lead to complete cessation of menses or periods after 3 to 6 months. Some common side effects would be cramps and pain during placement and afterwards, as well as irregular bleeding. The copper IUD lasts up to 12 years and has no hormones. So this is very good in someone who may have a contraindication to hormones or wants a really long-lasting but reversible form of contraception. The IUD works by stopping the sperm and egg from meeting and changing the lining of the uterus and the womb. Again, the copper IUD is associated with irregular bleeding and spotting, as well as sometimes heavier periods overall. All IUDs require the clinic visit for placement, and they do not protect against STDs. Some of the other side effects is that they can fall out of the uterus, and they actually have a string attached where you can feel it inside. So you can notice when it falls out, and that typically happens in the first 3 months after insertion, as well as there can rarely be a puncturing of the uterus when it's in or during placement. That is serious. Go to the next slide. So since these are systematic, the hormones are in your body, there are side effects associated with these. Some common side effects associated with hormonal contraceptives are nausea, headaches, abdominal cramping, breast tenderness, an increase in vaginal discharge, and decreased libido. Estrogens do have the benefit of decreased acne, and they do lower your risk of ovarian cancer. There are a few absolute and relative contraindications to consider with combined hormonal contraceptives when initiating them in a patient. For example, you would want to avoid starting them in a patient with uncontrolled hypertension, smoking over the age of 35, known ischemic heart disease, and history or active breast cancer. So estrogens increase your clot risk in women. And actually, when the pill, the combined hormonal contraceptive, first came out, it had much higher levels of estrogen and led to a lot of women, young women, actually having blood clots. So there is a risk of that. So in patients that are higher risk of thrombosis, such as the ischemic heart disease or the smoking, it'd be good to avoid the combined hormonal contraceptives. A good thing to note is that you can use progestin only. So there is a progestin only pill that is used similar to the combined pill, where you take it every day for 21 days on, 7 days off. That one is frequently used postpartum because you don't want the estrogen in the breast milk of the mother. So you use the progestin only pill, or in patients with a higher clot risk. Something to note about the progestin only pill is that it is less effective than the combined pill, which is why it's not used in the general population. And also it has to be taken within the same 3-hour period every day. And that if you miss the timing of the pill by more than 3 hours, you should use other protection when having sexual intercourse for the next 2 days. And then the risk of breast cancer. So estrogen and progestin both increase your risk of breast cancer. So if a woman has a known history or active breast cancer, you want to avoid any hormonal contraception. This would be when using a barrier method, or a copper IUD would be a good alternative. So again, going back to this is just showing things to consider when discussing contraception with a patient. Some good things to think about are accessibility to clinics and affordability of different methods, as well as ease of use. If a patient is worried about compliance with a pill every day or with using a condom effectively, one of the longer term ones, such as an implant or injection, are good alternatives because then they can just do it once and not have to worry about it for a long time. Also, the condoms are usually easily accessible and very cheap if a patient wants a method without any hormones or any medications or procedures. You can go to the next slide. So again, kind of what I said, just thinking about when starting a contraceptive method, consider the safety, effectiveness, availability, and acceptability. And then there's also emergency contraception. So this is progestin pills and copper IUDs. The progestin pills are used within 3 to 5 days after sex and have a really high dose of progesterone that will cause uterine lining to shed and to prevent pregnancy. These are often used if they've had sex without contraceptive, if there's been a sexual assault, or if they have concerns about possible contraceptive failure. And then copper IUDs actually can be used as emergency contraceptive as well. And according to the WHO, they are the most effective form of emergency contraception and can be used within 5 days of sexual intercourse. And then the woman will also get the long-term benefits of the copper IUD protection. So that's something to note. And in the pipeline, so there are looking at male hormonal contraception with testosterone. And so this would kind of create a feedback loop that with suppression of LH and FSH in the man that will hopefully lower production of sperm, therefore rendering the man sterile temporarily or reversibly. And so this is an injection and a pill that are both being studied. There are currently phase 3 clinical trials in India and some other countries using injections for male contraception. So this would be a nice way in the future for a man to have a long-term method of protection. Again, there are questions on cultural acceptability of this kind of birth control, as well as the use of injections if the pill is not developed. You can go to the next slide. Thank you. So in North and South America, prevalence is pretty high for modern contraceptive methods. In most countries, it's between 60 and 76%. I know it's a little hard to see, but that data is from the Pan American Health Organization. And many of the countries in North and South America offer over-the-counter or behind-the-counter access to emergency contraceptives. So this graph I showed you is from an article in The Lancet, which shows that rates of unintended pregnancies have fallen between the 90s and the 2010s. So there have been improvements in cultures and in contraception use over the last 20, 30 years that have led to a decrease in unintended pregnancies in North and South America and around the world. But there's still a lot of room for improvement in both access and information about birth control methods. And I think as providers, as pharmacists and medical students, we're well positioned to teach our patients about access to birth control and contraception, how to use it effectively, and what would be the best method for them to use. And I think it's important to teach this to both male and female patients. And as what she was saying earlier, comprehensive sexual education is an important part, and contraceptive use is an important part of comprehensive sexual education. These are some helpful links. So the WHO has a lot of interesting resources on it, and the CDC does as well. The website at the bottom, bedsider.org, is one that I really like, even if it is geared towards the United States. This is a very patient-friendly website that goes over a lot of different forms of contraception and it's really easy for English-speaking patients to understand on that website because it's all in a patient-friendly language. And it talks about effectiveness and reversibility and ease of use and things like that. So there are a lot of resources out there, and I think it's also important for us to be able to direct our patients to these websites as well as have physical materials and ways for them to learn more about it. And again, this is just the IPSF PARO information. We're on Facebook under IPSF PARO, as well as Instagram, Twitter, and YouTube. So that's all I have today. Thank you all for having me. I think we're opening up for questions next. Is that right?
It is. Thank you so much, Ethan and Fatih. Just a reminder to everyone that's joining us, you can still make questions whether it's on the YouTube Live, in our case, in the America's Facebook group or WhatsApp chats, and on IPSF's media as well. So we do have one question, actually two of them, but I believe they're related. Question comes from Eugenia Peñafiel, and she says, do you believe interprofessional collaboration is important to achieve comprehensive sexual education? And what do you think the role of pharmacists is? So I'm gonna go with Ethan. If you could help us with this question, please.
Yes, of course. I think interprofessional collaboration is always helpful in terms of creating a comprehensive patient care experience, because I think the more connected the pharmacists are in the community and in the clinic with their providers, both doctors and nurse practitioners, the more organized the patient care will be. And I think in terms of contraceptives, the pharmacists have a good role because the easiest access for the patient if they need emergency contraceptives, if they want barrier contraceptives like condoms and stuff. So I think having the community pharmacist be there to be able to talk to patients when they have questions about using the morning after pill or using condoms, that we can be there for them. And I also think, it's good to have these established connections with clinics and providers in order to recommend places for patients to go to learn more about the hormonal forms of contraceptive and other forms of contraception that their doctors will be able to talk with them about, and then they'll fill at the pharmacy.
Perfect. Thank you so much, Ethan. Maybe Fatih, you would like to add whether interprofessional collaboration is important to achieve CSE?
Yes, of course. So obviously, it's super important to have interprofessional collaboration inside the CSE, because CSE is not only responsibility of health professionals and teachers. As you can see inside to the CSE, we have social topics, we have cultural topics too. So we need to have a super comprehensive approach and taking account, for example, psychologists, teachers, gynecologists, pediatricians, the society in general, because we can in first place we can have a more comprehensive approach, and we can normalize the CSE around the society, because right now is not good receiving this kind of education inside to the American society.
Perfect. Thank you, Fatih. We have another question. This one's directed towards Ethan as well. Ethan, what do you think about male contraceptives, and also if this is going to change the role of women being the ones in control of contraceptives in couples?
Yeah, I think there is, a need for having another form of birth control that a man can use other than just condoms or barrier methods. I think having long-term reversible birth control is important to help lowering the rate of unintended pregnancies around the world, because having both partners be able to have this long form of birth control gives them both, I guess, more balance in the relationship. And I think in terms of the woman being in control, I think, even today a man can use a condom if he wants to, or different things like that. But I do think it'll be good in order to have both parties be able to have long-term forms of birth control.
Thank you, Ethan. Anything you want to add, Fatih?
So I believe in the gender inclusion, and I believe in gender equality. So we already have some options for women, but obviously that options are super expensive right now. So for prevent disease and for have a good sexual behavior, I think we can access in an easier way to male contraceptive methods, because in a cultural way it's easy for a man buy these kind of contraceptive methods. So it's okay if the people want to use that kind of contraceptive methods, but I think we can share more information about female contraceptive methods, and we can provide more empowerment for women, because obviously our option is exists options, and we can use it too.
Thank you so much, Fatih. So I don't have any more questions at the moment. We're just gonna wait for around a minute or so to see if anybody else has any questions. Once again, reminder, you can at them on the YouTube live stream or on the different social media, both IPSF, Pan American Regional's Office, or IFMSA's. So we're just gonna wait for a few minutes. While we wait, I just wanted to remind you as well that we still have some upcoming webinars. This is also an open invitation to IPSF's members if you want to join. This is actually our 12th edition or session of the webinars, but we still have 2 more weeks of webinars. So just you can join if you want to on Monday. Our next webinar will be related to gender-based violence in times of COVID-19. So you're totally invited to attend. Okay, yeah, I don't see any more questions. So I'm just going to open up the floor for any final comments from Ethan or Fatih.
I think there's one more question.
Oh, there is. Sorry. Yes, from Omar. Omar is actually our animal president from Jamsa, Jamaica. He says, hey guys, I live in a country where talking about sex is a taboo. What can we as students do to advocate more for CSE in schools? So let's start with, I don't know, with Ethan. Do you want to go?
I think Fatima may be better suited for answering this one.
Sure thing. Go ahead, Fatih.
Thank you, guys. So almost in all the region is super complicated to talk about sexuality because for us, talk about sexuality is talk about sex, and sex is a taboo topic here in the region and almostly in all the regions around the world. But I think the key here is the normalization and show all the components around the CSE in general, because we need to teach not just about sex. We need to teach about gender roles. We need to teach about GBV, gender-based violence, and we can teach about STEs, and we can show the benefits of share this kind of information. Because even if we don't talk about sexuality, even if we don't talk about comprehensive sexuality education, the young people is having sex. And maybe this sex is unhealthy or they are having high risk actions around sexuality. So we need to work in the normalization, and we need to create some spaces for talk about sexuality in general. And we can create a more inclusive environment for sexuality in young people, because sex is a natural thing. And again, we live in a super hypersexualized world. So if we have easy access to sexual content, we need to prepare and we need to provide skills for have correct sexual behavior.
Perfect. Thank you, Fatih. No more questions. Actually, that's a comment. Let me just check out. Yep. Okay, now I really think we don't have any more questions. Either way, if you still have questions on this topic, you can still contact any of us. You can still add questions and we will try to answer them afterwards. So yeah, I'm just going to open up any final comments. Fatih?
Well, I just want to say thank you for this space. And I think in the region we are working for create better and more inclusive spaces for sexuality, and we are working for create a more inclusive world and a more inclusive region. So thank you again for create these spaces for talk about sexuality, and for share with us information and share with us questions, because with this we can eliminate the stigma around sexuality and sexual education.
Thank you so much. Ethan, any final comments you would like to share?
Yeah, and I wanted to say thank you to everyone for having us and for hosting these webinars. I think this is an important topic to talk about. And as you said, working with comprehensive sexual education is important. And I think with us being future providers, both doctors and pharmacists, it's our responsibility to be the ones, to learn about the different forms of contraception and to know how to use them effectively and what their side effects are and who should use them, so that we can be a valued resource to our patients and to be able to spread to our community about contraception and hopefully, break down the stigma of or taboo against talking about it if we're in positions of authority and are talking about it with our patients. So I think we're in a good spot to do this, and that these webinars are a good step forward.
Thank you so much, Ethan. Now I'm going to open the floor for Mr. Jean-Pierre Regalado, who is IPSF from the Pan American Regional Office's chair. So, Jean-Pierre.
Okay, hello everybody. I want to thank you to Maria Jose for invite us as IPSF to have this joint webinar with all of you and deliver this very interesting and I think not well touched topic around the world, because overpopulation is a problem nowadays, and teaching people how to use contraceptive methods and sexual education is pretty important as healthcare professionals to deliver this issue. So just thank you to Maria Jose again, and I hope to see you again in a next webinar. And it's incredible, this webinar series to have you are holding, and thank you for that.
Thank you so much. So I think we all agree on the importance of this topic. It was amazing to have this collaboration with you guys, and hopefully we will be able to collaborate on more topics and more different activities together. Once again, thank you a lot, Fatih and Ethan. The contents delivered today were amazing, and the subject itself is really important. I hope that we can together shape and, as you mentioned, actually eliminate stigma and get all of the people from Americas informed and work together towards common goals. So that will be all. Thank you once again, guys, and I'll see all of you once again on Monday. Bye, everybody.
Bye.
Goodbye, guys.